My dear students, in this video, I am going to discuss some salient points concerning burn shock and the management in the ICU. Now, a burn ICU is often considered as the hell on earth because the burn patients are the worst sufferers of tragedies in which the outcome is not only variable and runs downhill often, but actually everything occurs as with the patient remaining a direct witness to this downhill course. So he experiences that all the difficulties from time to time, and the outcome worsens in front of his eyes. Let us walk along this case and we will see the management practices and how to go ahead with such patients. A 35-year-old female was brought to the ER 1 hour after sustaining flame burns in a house fire. On examination, she had 45% of total body surface area involving both deep partial and full thickness burns that involved chest, abdomen, and both upper limbs. On examination of the airway, she had a hoarse voice with singed nasal hairs, singed because of the carbon particles in this interspersed in that anatomical area, which was concerned for inhalation injury. On examination of the vitals, she had a heart rate of 138 per minute, a BP of 88 by 54, respiratory rate of 28 per minute, temperature 35.8 degrees centigrade, SpO2 of 94% on room air. The urine output was 10 ml in the 1 hour, which was very low, and that was only a rough estimate based upon the history. On ABG, patient was acidotic, pH was 7.28, bicarb was 17, the lactate was 4 millimoles per liter, hematocrit was 52%. So based upon these findings, the patient was diagnosed as a major burn injury involving 45% of the total body surface area with early burn shock and probable inhalation injury. So what is burn shock? Burn shock is a unique combination of both hypovolemic and distributive shock following excessive thermal injury. And typically, this thermal injury exceeds 20% of the total body surface area in adults or 10% in case of children. It has been seen, according to a recent global analysis published in The Lancet, that 8.38 million new burn cases occurred in 2019 alone, and which was a significant number worldwide. And in 2019, it was estimated that 23,000 fire-related deaths occurred in India, which was represented about 20% of the global fire-related mortality. That also came in Lancet 2 years later in 2021. Now, this burden is also heavily skewed because 70 to 90% of the burns occur in low and middle income countries, as is known. So probably the load on the burn ICUs is much more in the middle income countries because the ICUs may fall short of the need. The dedicated burn ICUs is what I mean. And therefore, some of these patients may require admission into the other normal ICUs. And they should also provide the same level of care that is expected in these patients, which are determined in the burn ICUs as well. So what is the mechanism of shock in burn shock? One, there are fluid shifts because of increased capillary permeability due to plasma leakage into the interstitium, which leads to a diminution of the intravascular volume. Then there is reduction in the oncotic pressure because of loss of plasma proteins along the same leakage like albumin. And this leads to accumulation of tissue edema in the burned and unburned areas because the fluid accumulates in the extravascular spaces. Second, the vascular changes because of vasodilatation due to the inflammatory mediators. And this is what is responsible for the distributive component of the shock, as in contrast to the hypovolemic shock, which was explained by the fluid shifts. So among the vascular changes, sluggish microcirculation because of this vasodilatation causes tissue hypoxia, and that worsens the acidosis and causes organ dysfunction. Third is the inflammatory cascade because the cytokines like TNF alpha, interleukin 1 beta, and interleukin 1 6, all of these cytokines are released, and reactive oxygen species leads to endothelial injury, which further increases the permeability of the capillary, and whatever fluid that is given during resuscitation oozes out from the intravascular compartment. And there is complement activation with capillary leak and leukocyte adhesion, and thus a very vicious cycle progresses till the time that this inflammatory process gets arrested by its own natural course. And the fourth is myocardial depression, which causes decreased cardiac output initially, that is during the ebb phase, but after 24 to 48 hours, there is a flow phase in which the patient goes into a hyperdynamic circulation. So this is very simplistically trying to explain the mechanism of burn shock. It is much more complex, and there is much more intertwining of the factors, both physiological and non-physiological, which ultimately culminates along the common pathway to produce increased inflammation, increased capillary leakage, etc. So what are the resuscitation principles in ICU? There are two main goals of resuscitation whenever a burn patient is brought in the ICU as an emergency. It is always brought as an emergency, that to restore and maintain the tissue perfusion and organ function, and two, to avoid both under resuscitation and over resuscitation, because under resuscitation can be harmful as it may lead to shock, AKI, etc., while over resuscitation can also lead to pulmonary edema, heart failure, compartment syndrome, etc. So both are harmful. So the first step in a burn patient is fluid resuscitation because of taking care of the hypovolemic compartment, hypovolemic shock. So the fluid resuscitation that is practiced in burn patients actually connotes with two formulas that are commonly used all across the world. One is the most commonly used is the Parkland formula. In Parkland formula, we multiply 4 times with the body weight in kg into the percentage of total body surface area burns, and half of this is administered in the first 8 hours. The remainder is administered in the next 16 hours. So this is the total for fluid that is given over 24 hours. Now one has to note that it is not just a formula based. One has to consider monitoring this fluid and how much of it is correcting the fluid loss and how much of it is maintaining the ongoing losses, so that there is not overhydration. So always we have to count time from the injury and not from hospital admission. That needs to be remembered. For example, if a 70 kg man has a 40% burn, so 4 times of 70, that multiplied by 40, because 40% burns, gives a rough estimate of 11,200 in 24 hours. So 5.6 liters of fluid is required in the first 8 hours, and the remaining 5.6 liters in the next 16 hours. So if the patient has presented after 1 hour or 2 hours, so accordingly, the remaining should be administered within the 14 hours or 15 hours, as the case may be. There is another formula, which is the modified Brook formula, where we give administered twice the body weight in kg multiplied by the percentage of total body surface area of burn. And half of this is administered again in 8 hours and the remaining half over the next 16 hours. So in children, we use maintenance plus Parkland because they have higher surface area to volume ratio, which causes more loss due to evaporation. And one more thing we have to remember is to avoid colloids in the first 8 to 12 hours due to capillary leak, because we have to consider them after 12 to 24 hours when the leak has subsided, and we can administer albumin 5% if the ongoing high requirement of fluids is there. So this avoidance of the colloid has to be remembered in patients with burns. Now, as in any other shock patient, in burn shock also we proceed along primary and secondary surveys. In primary survey, it is A, B, C, D, and E, where A is the airway. Since the patient had hoarseness and singed particles, carbon particles, so early intubation is recommended before airway edema worsens, at which time it may be also technically difficult to intubate the patient, or it may not be so quick. Use endotracheal tube with cuff and prepare for difficult airway. Use 100% oxygen. Check carbohemoglobin level to rule out carbon monoxide poisoning. If the carbohemoglobin level is more than 10 to 15%, we have to give 100% O2 or hyperbaric oxygen if it is available. If cyanide is suspected because of closed space air, we have to consider on administering hydroxycobalamin. After airway comes the breathing. So we have to check for circumferential chest burns because they restrict expansion of the lungs and the chest wall more correctly, and they may need eschorotomy. And also we monitor the ABG and maintain the saturation between or above 94%. Coming to C, or circulation, we have to start fluid resuscitation as I narrated immediately, and use the Parkland formula because that is the most widely used formula. And half of this is administered at the first 8 hours after the time, and the next half within the 16 hours. And as I mentioned before, since this patient had presented 1 hour later, so the remaining 6,300, that is the second half fluid, should be, the first half fluid, that is the 6,300 ml of the first half, that has to go within the 7 hours instead of 8. So the rate you roughly calculate to be around 900 ml per hour, and we have to titrate as per the urine output. Of course, looking into the other targets. So what should be the monitoring targets? Again, the same as what is in other shock patients, urine output of 0.5 to 1 ml per kg per hour. That is 35 to 70 ml per hour in a 70 kg man. And the MAP should be more than 65. Lactate should be improving, either less than 2 millimoles per liter or decreasing at a rate of 25% over the baseline value every 2 hours, and the base deficit of less than 2. So the monitoring should be done for increasing abdominal girth, rising intra-abdominal pressure, or respiratory compromise because they may signal abdominal compartment syndrome. In primary survey, what we are left with D and E, that is disability and exposure. D is CNS. So in our patient, the GCS was 15 by 15. We administered analgesics, that is IV opioids. We can also use fentanyl or morphine, but avoid intramuscular injections because of unreliable absorption and too much of dose, not ultimately producing effect on the but rather than on the benefits, but rather than causing some harm. And the E stands for exposure or environment, where we have to remove all burned clothing, jewelry, etc., cover with sterile sheets, maintain ambient temperature between 30 to 32 degrees centigrade, use fluid warmers to prevent hypothermia, and so on. Secondary survey, where the resuscitation endpoints are assessed every 6 hourly, we target a urine output of same of 0.5 to 1 mils per kg per hour. We check the investigation, CBC, RFT, LFT, and electrolytes. The MAP, we target more than 65 millimeter mercury, and we follow the investigations ABG and lactate to check that. Base deficit less than 2, and the investigation we look for carboxyhemoglobin. Lactate less than 2, we look for urine for myoglobin to rule out rhabdomyolysis. And capillary refill time more less than 2 seconds because that will baseline wound swab, but is suggested, but it should not for routinely or daily use of routine samples. Now, wound care and infection control is one of the major areas of concern in burn patients because burn patients can harbor a lot of infections which may flare up during their ICU admission, or they may acquire those infections in the ICU while they stay in the ward also. So if the patient has for asepsis, we have to strictly look into sterile handling, and dedicated dressing area should be present for these patients. Topical agent like sulfadiazine cream 1% or mafenide acetate is very useful. Dressings non-adherent paraffin gauze and along with sterile gauze is useful. Early debridement, that is removal of the necrotic tissue to prevent sepsis, and early grafting, that is grafting should be done within 5 to 7 days if patients become stable. And we have to monitor infection, like if there is fever, leukocytosis, wound color change. Culture guided systemic antibiotics should be started only when invasive infection is suspected. Now, what should be the antibiotic policy and surveillance in burn ICUs? The antibiotics policy should be based on antimicrobial stewardship. No routine prophylactic systemic antibiotics should be administered, although we know that sometimes it is difficult to implement it. But we have to start systemic antibiotics if the wound infection with systemic signs are there, like fever, rising CRP or rising lactate, and leukocytosis, along with positive cultures after bearing a clinical correlation with the findings. We use empiric broad spectrum coverage like piperacillin tazobactam with or without amikacin, or cefoperazone sulbactam with or without vancomycin, only if septic shock is present, and after that we de-escalate as per the culture sensitivity. Now, culture sensitivity is a very important laboratory investigations that guides us about the antibiotic use in cancer patients in the ICU. Now, the baseline wound swabs are required to be checked weekly for surveillance and not for treatment, of course. And blood cultures should be sent if the patient is having fever or shock. Catheter tip only if suspected line infection. And we have to maintain the burn infection surveillance. So the logbook should contain pathogen resistance pattern as well as the outcome. So there are some challenges in the burn ICUs of our country. Challenges particularly like overcrowding, which can cause cross infection, and therefore we need solutions like cohorting and staggered admissions to accommodate burn patients. Limited isolation rooms in India is also a challenge, which causes increased exposure of the disease, and the solution lies in providing physical barriers, curtains, and zoning. Resource limitations, so the impact is on reuse of items. So the solution lies in the use of local disinfectants and limit reuse. Then the prevalence of high MDR organisms is also a challenge in Indian burn ICUs, whose impact is not only on the occurrence of sepsis, but also on high mortality. And the solution lies in strict stewardship, decontamination, and infection audits. Staff crunch or staff shortage is also, again, a limiting factor in Indian ICUs, which leads to poor compliance of the established guidelines. And the solution lies in building a dedicated burn team with periodic retraining so that they are up to date with the advancements. So the empiric therapy, how they would look like in Indian ICUs, if the patient has wound sepsis, the likely pathogens are Pseudomonas, Acinetobacter, MRSA, etc. And the empirical approach should be carbapenem plus minus colistin and vancomycin if there is either the patient is harboring MRSA or at the risk of harboring MRSA. In VAP, the likely pathogens are the MDR gram-negative rods, and again the empiric approach is either meropenem or polymyxin along with inhaled colistin or IV colistin. In cases of line sepsis involving the central venous catheters, etc., MRSA and Candida are the likely pathogens, and vancomycin plus minus echinocandin is a empiric approach. In cases of UTI, again gram-negative bacilli and Candida are the likely pathogens, and piperacillin tazobactam or fluconazole only if there is a fungal suspicion is used. Otherwise, piperacillin tazobactam can be used confidently. So there are certain other problems too. like how to monitor nutritional. So this is the empiric therapy is which of Indian ICUs, that is largely based upon the practice in the major centers of the northern and southern part in India. And we have some studies which have been published in the Curious also and in the BMJ also. So they reflect some of those studies which highlights the status of empiric therapy in Indian ICUs among the patients. Next is nutrition. Nutritional adequacy is also very important for the recovery of burn patients. Without nutritional adequacy, we can't expect them to recover on time. And if they don't recover on time, it is a loss of hospital beds, it is loss to the family members, etc., etc. So we have to monitor the nutritional adequacy by looking into the parameters like weight, which has to be monitored twice weekly, and one should target stable or minimal loss. The nitrogen balance should be monitored 2 to 3 times a week, and the target should be either it is neutral or positive. Prealbumin or as transferrin should be monitored weekly, and rising trends usually indicates adequacy. Blood glucose should be checked 4 to 6 hourly, and the target of 110 to 150 may be optimum. Electrolytes, magnesium phosphate should be monitored daily and should be maintained in the normal range. And residual volumes or bowel sounds should be monitored 4 to 6 hourly. And the target is that less than 200 ml is considered as acceptable. So if you look into the nutrition, early enteral feeding within 6 hours of resuscitation maintains the gut integrity. The calorie needs can be calculated roughly at 20 kilocalories per kg per day plus 40 kilocalories into total body surface burn. So in our patient, it was body weight was 70 kg, so 25 into 70 plus 40 kilocalories to percentage of surface area burnt. So surface area burnt is 45, so it is 40 into 45, which turns out to be 4,300 kilocalories per day. Protein is 1.5 to 2 grams per kg per day. So that comes to around 110 to 140. So micronutrients like vitamin C, vitamin E, zinc, selenium, copper supplementation, these are all considered important strategies for improving the nutrition. So early enteral high protein immune modulated feeding saves lives as much as antibiotics or surgery. Now let us take the example of a 70 kg man with a 40% total body surface area burns. The components, if you look into the energy, according to the query, 25 into 70 plus 40 into 45, that is 3950 kilocalories. Protein requirement is 2 grams per kg or 140 grams per day. Carbohydrate is 55% of the total energy, that is roughly 2100 kilocalories. And fat around 25%, that is 950 kilocalories or roughly 105 grams. The fluids for feeding, that is 2 mils per kilocalories or 7.6 liters. So it has to be adjusted to the IV to the enteral ratio. Now the plan should be to target around 3,800 kilocalories per day, high protein feed, that is 20% of the calories, continuous feeding. One has to prefer omega-3 mix and concentrated formula to avoid overload. So many a times in order to avoid overload, we also give antibiotics in minimal dilution and take such steps. Regarding pain, sedation, and stress control, all of these are important elements in a patient of burn in the ICU. So analgesia we can improve by IV morphine or fentanyl. One should avoid the intramuscular routes. Sedation in ventilated patients can be managed with midazolam, and propofol should be titrated. Stress ulcer prophylaxis should be treated with pantoprazole or famotidine, and DVT prophylaxis should lead us to conclude about low molecular weight heparin unless contraindicated. So if we look into the category of pain and the drug and the purpose for which it is being used, it will become more clear to us. Like for baseline analgesia, we use morphine, fentanyl, paracetamol. All of them cause continuous pain control. For procedural pain, we use ketamine, remifentanil, and propofol. and the purpose is dressing or debridement. Sedation, the drug classes will be dexmedetomidine and midazolam. Uh, and the purpose is anxiolysis and sleep. For neuropathic pain, gabapentin, pregabalin, and the purpose is healing the face pain. Adjuncts like clonidine and amitriptyline, which reduces the opioid needs, and none but not the least, there are non-pharmacology measures like music, cooling, cognitive behavioral therapy, etc., which serves as adjunct to the level of comfort. So burn pain is dynamic. Analgesia must be proactive, multimodal, and regularly reassessed. So we have to watch for complications like in cases of over resuscitation, excess fluids can lead to edema, abdominal compartment syndrome, etc. So one needs to titrate fluids, measure intra-abdominal pressure if it is required, and also do a fasciotomy or eschorotomy if there need be. For under resuscitation can lead to hypoperfusion, which leads to AKI and acidosis. So we have to adjust the fluids, can consider vasopressors if the MAP is less than 65 despite adequate preload without giving them more fluids further. Sepsis or MODS, we have to think about burn wound colonization, and early grafting and targeted antibiotics can improve the situation. ARDS with inhalational injury and SIRS, we have to think about lung protective ventilation. With AKI, with hypovolemia or myoglobinuria leading to AKI, we have to manage with adequate fluids alongside urine alkalinization. For GI bleed due to ulcer, etc., with it can be because of stress or hypoperfusion, we have to think about PPI prophylaxis. There are some special situations like electric burns where deep tissue injury is there despite small surface burns. So we have to look for that. Myoglobinuria occurs early, needs to be treated with aggressive fluids and alkalization of the urine. Then there are chemical burns where there is copious irrigation and there are specific antidotes should be used if they are known. And in pediatric burns where because of smaller fluid reserve, higher maintenance needs are necessary and they have greater risk of hypoglycemia. So we need to add 5% dextrose to the ringer lactate. So my final take-home message would be that in burn ICUs, where the patient presents with a burn shock, always handle the airway early and intubate before it is too late, because at that stage, because of edema, it may be a difficult situation and one can expect a can't intubate, can't ventilate kind of scenario. Fluids guided by the urine output, not the formula alone. Because if we get guided by formula alone, there are chances we may tend to give more fluid, ultimately giving rise to edema and all the adverse consequences. So avoid both under and over resuscitation and start early enteral feeds if possible within 6 hours. Early wound excision and grafting to prevent sepsis so that the source gets eliminated, and also don't use prophylactic antibiotics unless there are definite reasons to use so, and prevent hypothermia, infection, DVT, and ulcers. Thank you very much.